Okay, so hello everybody. My name is Owen Johnson. Delighted to be here today to talk about process mining as the prerequisite for AI in the NHS. So I'm going to obviously talk to you about process mining, but I'm also going to try and make an argument that doing process mining is really important before we try and introduce AI in the NHS. So as a partly then I'll talk a little bit about AI. So just to kick off, a little bit of background for me, I'm an associate professor at the University of Leeds in the School of Computer Science. I've worked for many, many years in health and medicine, around about 20 years, I think, all told. And most of that time I've been in digital health, and a lot of that time has been in electronic healthcare record data. Around about 10 years ago, I discovered process mining and it changed my life. So I kind of want to share that with you all and talk about what I know about process mining as a kind of intro. So I have a few other roles. Probably the most important is that I am a director for a centre for AI medical diagnosis and care, where we're training 50 PhD students in AI. And that will come through. I'm also on the MHRA's National Commission for the Regulation of AI in Medicine, or AI as a medical device. So I'm kind of interested in thinking through how AI can be deployed in the NHS. And my particular hobby horse, which is what you're going to hear about today, is how process mining might be a tool that might help. So the abstract was circulated to you already, but if I kind of kick off with the framing sentence is the NHS needs somehow to have shorter waiting lists and better, faster, more effective care pathways. And that's the kind of frame. We all know that, I think. And the starting point is there, and the government, Wes Streeting, Department of Health, NHS England are all keen, and I'm sure everybody here on this call is also keen to see what we can do to give better care, and somehow miraculously cheaper and faster as well. So I would kind of hope the first bullet point, at least the first sentence, you'll agree with. So we can and should be using AI that's trained on NHS data to understand how we can improve it. But I guess most of you have got some strong data mining angles. Oh, somebody's got their microphone on. Thanks. Okay. So what I want to do is introduce you to process mining and try and convince you that data mining doesn't have all of the answers, and the extra bit of toolkit that you might need to understand how to improve care pathways is something called process mining. So process mining is a little bit of a bridge between what we might see as data science and then what we might see as process science. So process science would be things like process modeling, process improvement, lean, digital transformation. So the whole range of different words about process improvement in healthcare. In the 10-year plan, there's a plan to roll out huge amounts of AI. And so what I'm going to try and do is make the case that this isn't going to work. And it could indeed be clinically unsafe and create bias and health inequalities if we introduce AI without first trying to understand what the care pathways are before we try and use AI to improve them. And I'll show you how process mining can be used to do that and create guardrails. And I'll give you some examples. I should have said at the beginning that I have an academic fellowship to help introduce process mining into the NHS, and I've been working with the NHS England process mining team under Tim Greatrex to try and find and build examples of good process mining practice. So if you want to follow up on that at the end of this talk and in emails subsequently, that'd be great. Really interested to do that with you. And I've developed a methodology called ClearPath, which I will show you at the end of this talk and describe a little bit about how it might work. So that's the abstract. I thought I'd start just with a little bit about AI. It's around about 75 years old, which is round about same age as the NHS. So the AI and the NHS, 75 years old, about time they met each other. And you'll be familiar with things like the Turing test and the idea that AI that could be, the Turing test was to decide whether AI was as intelligent as a human, and the idea being that if you put a human and an AI in a room, could somebody else tell the difference? And we're kind of way past that now, because actually the way you can tell it's AI is because it's smarter than the average human. So AI's kind of come of age in the last couple of years, particularly with ChatGPT and large language models. But it's been around for a long, long time. So I pinned this date as 13th of Jan, so around about almost exactly a year ago, where Keir Starmer, a great Leeds graduate, outlined the AI action plan for the public sector, where he said useful things like we're going to be an AI maker, not an AI taker. So he promised that the government will invest in the foundations of AI, that they will rapidly pilot and scale AI products in the public sector. And by that, many of his examples when he did that talk were healthcare related. So there is a strong sense from the government that they do see AI as part of the answer to helping the NHS do more with less. There's some good evidence that the UK is well positioned to do that. So the data that they quote was from Stanford Global AI Vibrancy Report, and I've put the link there, and you probably can't see the diagram, but the UK is third in the world in terms of AI vibrancy, according to this report. So they're behind USA and China, but ahead of India. I take this with a pinch of salt. I think China's way ahead of the USA, to be fair. I'm not sure the UK is really third, but fundamentally it doesn't really matter. What matters for us is what do we do? Government want us to adopt AI at pace in the NHS. They're really, really keen for us to do that. As data analysts, data scientists, we really ought to be involved, because this is how AI is trained off of data. So I've got a few slides on AI, and I just want to talk those through to sort of set the scene. First one is hype. This is the Gartner hype cycle, which talks about every technology, whether it's AI or computer vision or anything, goes through a hype cycle, which starts as an innovation trigger, goes through a peak of overinflated expectations, falls into a trough of disillusionment, then works its way slowly up the slope of enlightenment onto the plateau of productivity. AI, as you can see, this was last year, but or 2024 now, AI was kind of right at the peak of overinflated expectations, which kind of suggests that they'll be dropping into the trough of disillusionment right about now. But we kind of expect AI to start becoming mainstream over the next few years. So yes, it's hype, but yes, it's also valuable and important. Things like artificial narrow intelligence is already mainstream, and a good example would be things like using Google Maps to plan your journey to work or to look at traffic as you're going somewhere. So that kind of AI, it's on our smartphones, we're using it all the time. We haven't really even thought about it as AI. So I want to talk about the potential for using AI in medicine. So I'm going to explain this graph to you. The horizontal axis is someone's life. Let's hope that we live for 80 years and we can go from birth through childhood, through maybe some acute and chronic acute episodes and chronic conditions, and living with illness until eventually death at some point. As we go through our life, we generate data. So the vertical axis is a logarithmic scale. You can kind of see that if you look at the axis, logarithmic scale of the volume of data that we might generate right from our ultrasound scans before we're born through to x-rays of our legs or arms or lungs, through to kind of quite serious major illnesses later in life. So we're generating terabytes of data through our life. So there's potential to use this data with AI to do good things. And the four good things that we might think about are prediction. So given what I know about this child, what's the likelihood of illnesses later in life? We might use diagnosis for things like looking at an x-ray and seeing whether that's x-ray of the lungs, see whether that's tuberculosis or chest infection or COVID. So the kind of diagnosis steps, and then retrospectively, if we look back at a patient's life history and all its data, can we work out causation and therefore help with detailed diagnosis and planning for future life. So there's lots of data being generated, being stored in NHS systems, and has the potential to be really, really life-changing and game-changing for the way we deliver healthcare. Especially when you think about, from a global perspective, 8.2 billion people on the planet. If we could take all of that data from all of those people, surely we could kind of build some AI that was really completely transforming medicine. And you will see and hear about in the press people that are doing some of that, but you'll also see a lot of that is hype. So I want to kind of leave that with the vision, and also kind of recognize that there are some challenges here. And just as an example of the kind of challenges that I've seen, I've worked with IBM Watson, where they tried to sell Leeds Hospital a melanoma detection, melanoma diagnosis through cameras and images, looking at skin, and they had trained the data set on Australians. And those of you that might see already the problem here is that Australians are very different to UK, much more sunshine, often white skin. So an algorithm that works in Australia is not necessarily going to work in the UK. And it might not necessarily work for people of colour. It might not necessarily work for certain people under certain conditions. The danger is that if we take an AI algorithm that's been trained on a different population to our own, it might be introducing bias and discrimination. So we kind of have to think quite carefully about how AI is trained and how we might set guardrails for that AI such that we could detect if it was biased against people of colour. How would we know? So I'll leave that thought, and I'll come back to that thought a bit later. So one of my friends at the University of Leeds, Peter Tennant, has kind of just recently done a kind of LinkedIn debate, which I've left the link there. And there's a kind of argument AI is not the future of health and social science. There are good reasons why AI is not going to work or is inappropriate in healthcare. And conversely, there are also very good arguments why AI is the future of health and social care and that humans aren't. So I'm not going to get into that debate right now, other than to recognise that there are two sides to this, and the answers obviously are somewhere in between these two extremes. So I want to talk about sort of how data from the NHS can be used practically, and that's where I want to come in. So we focus on Keir Starmer's idea of rolling out AI across the world to address things like waiting list and lead to this glossy, shiny future where patients are all smiling and happy, no waiting list, fantastic computer-based diagnosis. So if that's the mission, how do we do that? So we can think about putting some AI into a care pathway, into the middle of a pathway, and we might, for sake of argument, just let's assume the AI is a black box, as in we don't know how or why it works, it just seems to work. That's a kind of black box AI, and there are better AIs that are more explainable. But I think if for the purpose of this thought experiment, let's assume it's a black box and we're going to put it somewhere in the care pathway. The kind of questions that the clinicians and managers of your trust should be asking is, well, what AI? How is it going to be developed? What data will it use? How is it trained? And crucially, what are the risks and biases with this AI? And how might it be biased? And that depends on how it was trained. So that's a kind of development challenge, but there is also an implementation challenge, which is where in our care pathways could this AI be introduced? Now, if it was an AI for an X-ray, then you might think, well, radiology would be the obvious place. So sometimes it's obvious where the AI might go, but there will be upstream and downstream impacts. Wherever you put AI in the clinical pathways, it might make some things faster, it might make some things riskier, it might mean that it eliminates human beings from a pathway, but it might mean that we need human beings to check that the AI is right. So what are the real world implications? How will the users be integrated with the AI? And again, what are those risks and biases? So can our clinicians look out for those risks and biases and be prepared to override the AI if and when it's introduced? So if you're happy that this is the mission, for me, as a process person, I actually refine that slightly better. I want to know what is the current pathway, what's the as-is pathway, and typically I might model that with something like BPMN or UML, or just sticky notes on a flip chart paper or on a whiteboard, or by looking at the kind of documentation we have about what the clinical pathways are. Once you know what the as-is pathway is, we want to say, well, if we're going to introduce AI, there's going to be some kind of pathway improvement. So what will the future pathway look like? What's the design of that? Sometimes we call that the will-be pathway. So whenever AI is introduced, we need to kind of understand how does the pathway look now? How will the pathway look in the future? And will that give us the improvements that we expect and plan for? So that's the scene setting. That's kind of the a little bit about the background and context. Now, I have been working in this thing called process mining research for at least 10 years, maybe a bit longer. And I lead a team where we look at different medical domains across all different types of medicine and health. We try and get process mining. We use process mining, process simulation, process improvement, and iterative research to kind of identify care pathway insights and ultimately work towards a long-term goal of a learning health system where we take insights, implement them, and use the data to learn and iteratively improve forever. So learning health systems, fantastic long-term goal. Right now, what we can do is use data to deliver care pathway insights. So I'm going to talk about that. And I promise you, there's not very much academic theory. My only academic theory is this slide. This slide sort of starts from the premise that healthcare is complicated. And in academic world, we call that a complex system. And with a complex system, we understand that there are nonlinear behavior and emergent properties. And the most important thing about nonlinear behavior is that the relationship between what you put in terms of money, resources, staff, etc., does not necessarily lead to better outcomes. And this is the thing, we don't want to share this with West Streeting, but if you put more money in, it does not necessarily lead to better outcomes. The complexity of a care pathway and the complexity of our healthcare organizations is that their relationships are non-linear and are very, very difficult to predict. What we can do then is we can analyze what's going on inside our complex systems and try and understand particularly the feedback from data and how management might control care pathways using insights from data. So the tool set that I use is process mining, which is what I'm going to talk about today, process simulation, which I won't really cover, but process improvement, process modeling. So there's the tool set here. I'm going to focus on process mining today. Okay, and then this idea of complex systems means that there is a messy reality between the technology that we have, the processes that we run, the organizational structures that we have, and the people that are in those organizations. Change one of these boxes and the other three reshuffle, restructure. So we know, and you know, that real life inside the NHS is horribly, horribly messy. One of the constants is that we've got business information systems like healthcare APRs that are generating data that goes into data sets. So even though everything else is messy, we will at least have history in our databases. So there's a difference then between what might happen inside our healthcare environments and what we might imagine the pathway to look like. In between these two views on what a care pathway looks like, if you look very carefully, you'll see a computer screen just there. So the computer screens, the EPRs, the health information system we've got are doing two things. One of them is that they are actually controlling and supporting a process. So they are telling, in some cases, the clinician what's the next step, or they're actioning step after step. So in some ways they're involved in running the process, but the other thing they're doing is recording what happened in the process. So they're building an event log of all the things that happened. So I'm going to introduce you to process mining as a technique for looking at that data that's inside the just got that. Okay. So Chrissy, can I just check, or Brandon, can I just check which slide can you see? Can you see the process mining since 2005?
I can see process mining as a body of knowledge. It's only just switched though. To me, I'm not sure if it's me or others, but it's quite laggy.
It's laggy, isn't it? Yeah, I've just noticed that. So apologies to people if I've been talking out of sync with my slides. So let me. Right, okay, I'm going to do that. Okay, I'll talk about the slides that you can see because I've got a copy here. So process mining then is a body of knowledge that links between data science and process science and kind of unites the two. It's been going since around about 2005. The phrase process mining was coined by a Dutch professor called Will van der Elst, who's written various books about it. That's it. You won't recognize me, but that's a picture of me with Will last year. So I've been part of the process mining community globally for around about 10 years. Right. Okay. So I'm just going to check that. So laggy wise is still on that. It's very laggy, isn't it? So we should be on a slide saying process mining at its simplest, and I'm not sure
yet.
You can see that.
Not yet.
Okay, I'll slow down and then I'll kind of pause for a little bit.
Yeah,
how about that? Yep, good. Okay, apologies for the lagginess on the slides. I'll try and make sure I can talk to the right slide. Okay, so process mining at its simplest is to take the database that's attached to our health information systems and to select data fields of interest, of which the most important thing for me is timestamps. So if I've got timestamps for a case and some kind of name for an activity, I can create something called an event log, which is simply, for each case, what happened at what time through a pathway. And I can map that event log to a pathway model, which is what you see at the bottom, and start checking what's actually happened in the database versus what should have happened on a kind of model of what the pathway looks like. Okay, so slowly. So event logs then are typically, if you pulled an event log from your own hospital system, you might produce something like a spreadsheet, which might have a whole load of dates and times on it for each patient. So what you'll see in a minute is a hospital system event log file. There we are. So here's a spreadsheet from Leeds Hospital's Accident and Emergency Department. These are fictitious named patients, obviously, but you can kind of see that some of the activities are blank, some of the activities have got date timestamps on, and it should be possible for us to take all those activities and map them out to see what activities happen in what order, and then kind of create some summary statistics which will report back to say, well, ABC always happens, sometimes D&E happen, and then there are certain cases of certain frequencies that will run. So we can basically take a spreadsheet, take that data and analyze it. Hopefully with this slide you can kind of see an example of how you might do it. What we do with process mining is just use some more powerful tools to do the same thing. So we can take a tool set which will kind of automatically extract and take a database, find all the timestamps, and create event logs which we can pre-process. And there are various tools like Prom, which is an open source software tool, or Disco, which is a commercially available tool, but free for occasional use. So I recommend that. And you can produce these kind of directly follows graphs where you've got these blue boxes and arrows are saying what's the activities, what's the order, and then the thickness of the arrow is how many people go which way. So here's that spreadsheet I showed you of Leeds Hospital. Here's some data on that where we looked at, for example, the average time to be seen, which had a median of 3.9 hours, wait time in A&E, and we've got daytime and nighttime as being different processes in A&E. You've also got this kind of chart. There's a kind of X-ray vision of these dotted chart on the left-hand side are when activities took place for one day. So you can drill down into a process and look at it in depth, or you can kind of look at changes in a process over time. So I was going to just give you a couple of examples and case studies of work that we've done. So first thing to show you is a piece of work that we did for NHS England on East Midlands Ambulance Service, where we took what you might think of as a quite straightforward linear pathway from a phone call through to a hospital visit, and then mapped all of the data for East Midlands Ambulance Service to see what really happens in the database. And it kind of looks like this. This is a crazy spaghetti chart of all of the possible things that took place. So what we did with this is spent several months looking through data quality and mapping it and simplifying it to get a simpler pathway which we could use to, for example, so here this is a simplification of the pathway where we could work out the different outcomes from accident emergent from the ambulance, and which outcomes were most likely under what circumstances. So we used machine learning to try and predict the most likely outcome from the pathway and got reasonably good success rates. So I could work out around about a third of them were to do with the decisions at the original triage point. So okay, so a few other examples of how we can use process mining. This is a comparison between different hospitals of how they might run. So we've process mined different hospitals in Australia and America and looked at how the pathways compare. And you can imagine that we might be able to do this between different pathways in different hospitals in the UK. So another example is looking at the way that people left shift back up a pathway. So if they've been discharged from a ward and gone back into ICU, we might see that as a bad thing. So we've done work, again, using machine learning to try and predict when these backflows take place. So, when does somebody left shift back into an ICU or back into surgery? And with academic papers, we've got reasonably good results of predicting which patients will return back into ICU for surgery. Another example of what we can do is to look at the current pathway and then do kind of counterfactual of what a proposed pathway might look like, and whether that proposed pathway that will be future pathway, would that be better in terms of better outcomes, lower cost. So we've done work where we're kind of looking at, in this case, this is prostate cancer, a prognostic case for prostate cancer, which we did with data from Leeds. So the last of the examples I want to show you is how we might use process mining with AI guardrails. So this graph is showing you over time, the kind of reference range or the safe zone for an outcome. If you think about when we're using AIs, we might want to think about what's our percentage of successful prediction? What's our percentage of false positives? Have we guaranteed that we've got freedom from gender, ethnicity, and health inequality bias? Have we delivered on our business case promises? So there might be a whole set of guardrails that we might apply to the successful evaluation of a successful AI. With process mining, we can identify and then monitor breaches of those guidelines and then dig deeper into when we get a breach of a guideline, was that due to poor conformance? Was it down to sequences or unplanned events? What was it in the care pathway that led to a breach in the guidelines? So this is work in progress. I'm working on how we might use process mining to calibrate and test AI use process mining to calibrate and test AI within guardrails, and then deep dive as a root cause analysis against that kind of process data. So all of this is part of a methodology called ClearPath, which I've published and had reasonable success worldwide using, and I'm now doing some NHS England funded work, building case studies using ClearPath in the Yorkshire and the North East. ClearPath method itself is designed for process mining in an NHS England or NHS context, and so we've kind of adjusted an industry standard method to work well with the kind of challenges that we might face with the NHS. And in particular, the kind of key one, I think, is getting a clinical reference group to help frame and guide the work that we do. So I'm actually in the process of doing that with 4 case studies in the UK, sorry, in northeastern Yorkshire right now. But happy to discuss how we might do the same thing with yourselves in the southwest. So I'm kind of open to discussion about that later. The other couple of things I just want to say as I wrap up is that we've internationally, I've worked with colleagues to produce a process mining and healthcare manifesto, which we worked with on a 2-day brainstorming process with people from around the world, where we kind of looked at those particular challenges doing process mining in healthcare. What's the characteristics? What are the challenges? And we've kind of produced a recommended a paper which kind of describes those challenges, and then also talks about the kind of recommendations that one might make for addressing those in the future. So I think it's going to be in the next slide in a second. I should say that I've got another 2-day brainstorming workshop with many of the same people in March of this year, where they're all coming here to talk about how we can do process mining in the UK NHS. So that's kind of coming up next, and I'm doing a lot of preparation for that. So if we come back to the summary, then what I hope I've done is I've shown you a little bit about process mining and how it works and how it's a little bit similar to and different from data mining. We've talked a little bit about AI, and I've talked about where do we position this black box AI, what are the development and implementation challenges, and what I'm hoping to have done is kind of give you a sense of how process mining might be part of our toolkit for how we implement AI inside NHS care pathways. And I'm obviously trying to make the point that we shouldn't really be putting AI into our NHS until we're sure it's safe. And the only way we can be sure it's safe is if we understand what the pathways are now, and we've worked out what those guardrails are for safe and efficient care pathways, safe and efficient deployment of AI, so that we can be confident that AI is not killing people, or more likely it's just going to most likely thing is AI is going to have biases in it which will exacerbate health inequalities, and we're really trying to follow that logic through. So there's Will van der Elst has kind of produced a nice paper on this recently, which is using the strapline no AI without PI, where PI is process intelligence, so process mining plus. So if you're interested, here's the link to the paper, and he and I and other people around the world are kind of trying to make the case that process mining is absolutely essential if we're going to achieve the government's objectives and the NHS 10-year plan of rolling out AI at scale across the NHS.